Hi, I'm Olivia Rivellini. I'm a senior undergrad at the University of Pennsylvania, majoring in neuroscience and studying chemistry and bioethics. Today, I'll present on the medical model versus psychedelics, how psychedelics challenge the paradigms of psychiatric intervention. The goal of psychiatry is to diagnose, prevent, and treat mental disorders. We should pause and ask, what is the disorder we're treating? How are we treating it, and why? Our conceptualizations of mental illness stem from how we treat it, thus different results stem from different assumptions. Because changing a person's brain is a lot easier than changing their society or environment or life circumstances, psychiatry has an ethical responsibility to assess what treatment to offer and when to offer it. The values of the psychiatric medical model reveal a collective choice of philosophies, attitudes, prejudices of mental illness, notions about human health, values, and our goals. What we think works best depends on what we are trying to accomplish, which in turn depends on what we think is worth accomplishing, which depends ultimately on our philosophies. What our brains value and seek are greatly shaped by relationships and experiences in our families, communities, institutions, and cultures. We can be conditioned to value and seek not only the healthy objects and ideals that emerge in our unique environments, but also what can be unhealthy and harmful to ourselves and to others. Whether we are considered mentally well or ill, we all value, seek, and grasp at things that do not relieve our suffering, except fleetingly, and may also worsen it, and definitely don't heal our psychological wounds. Most of our behaviors, conceptualized as emotional dysregulation, are essentially habits of repeated choices, seeking to avoid and escape unpleasant and unwanted thoughts, memories, feelings, and bodily sensations. Our psychiatric practice must evolve to better address the complexity of how our values can shape the self-understandings, behaviors, and well-being of traumatized people, including diagnostics, understandings of the disorder, and treatment. We can ask, what can we bring to traumatized people and their brains, and their loved ones and their loved ones' brains, and the institutions, communities, and cultures in which they live, genuine healing, satisfaction, and well-being? It's first important to evaluate the current paradigms we hold in modern psychiatry and their moral assumptions. With the medical model, this entails regularly administering drugs to control psychiatric symptoms and correct pathological neurobiological states which afflict the patient. Neuroscience supports reducing the mind to a biological organ and mental illness to a brain disease. In this medical or pharmacological model, drugs are given to correct functional imbalances in the brain through a specifically targeted mechanism or receptor. I mostly want to speak to SSRIs and antidepressants for treating anxiety, depression, addiction, PTSD, and trauma. I think now it's important to comment that it's become trendy to think of people as neurochemicals, which stems from the monoamine hypothesis, which postulates that depression is a result of the depletion of serotonin, norepinephrine, and or dopamine. And this hypothesis that has not been proven to be causal of mental illness has false causal associations that could be really dangerous to how we view mental illness, including its etiology and its treatment. And as symptoms are best repressed or suppressed in the interest of getting on with a normal life, this reflects the values of our current society and economy and government. We have a lot of values of urgency and productivity, so these might deflect the actual values and wants of the patient themselves. The field of medicine operates on these societal values, which often dismiss underlying philosophical or spiritual concerns of the patient that may be at root of these symptoms. Next is the psychotherapeutic model. This is talk therapy or cognitive behavioral therapy or anything under the umbrella. The goal is to resolve inner conflict or psychological distress by bringing our unconscious emotions into full consciousness or conscious awareness through a therapist-patient dialogue. This process of identifying resistances and putting them into words aims to create change over years or months of corrective experiences. In this psychotherapeutic paradigm, you challenge problematic patterns of relating to yourself as a patient and to others by developing insight about the patient's past relationships and the relationship to the therapist. And it allows us to attend to personal and existential meanings that the patient's illnesses have for them and discover how these illnesses reflect the unmet or unknown needs of the person. And in combination, we have drug and talk therapy treatment, which is considered the golden standard of the medical system in terms of treating people with mental disorders. This is the golden standard because with giving drugs, you can alleviate symptoms that are problematic for later treatment. So giving the drugs like SSRIs or antidepressants allows you to better engage with your psychotherapy treatment for a synchronous treatment plan. Allows you to gain the capacity for introspection, challenging dysfunctional thoughts, cultivating self-compassion, practicing adaptive behaviors, and healing interactions with a therapist. And these all remodel the dysfunctional neural circuits according to the medical model. So to critique the current paradigm, first, I have to say that it would be unethical to not mask the symptoms of psychiatric disorder for these patients that have depression, anxiety, addiction, PTSD, and trauma. But we know that the drugs we give them are not doing anything to resolve their existential problems. Right now, there seems to be a huge pull and push between reactive depression, or the kind that relates to our environment and our life experience, and endogenous depression, where something goes wrong in our brain. Due to this current mental health crisis that is quite apparent, I'm not satisfied by the results of this paradigm, and there's much left to be wanted. So with these models that we have, we're put in this dichotomy of physiology and lived experience. With this model, it puts a chemical band-aid on the brains of those with deep trauma and existential anxieties, dread, and fear due to societal and generational factors. And this just demonstrates our collective fearful need to hide from self-awareness, and it limits the potential for better and more compassionate care of our patients. The medical model fosters a sort of delusory hope, promising patients an easy chemical normalization without their ever having to confront the existential crisis that is at the center of the pain. Whether or not it can be helped through other means, it's worth acknowledging that a lot of the suffering and trauma that we face is due to factors that could be changed but are not. So we are in need of a desperate need for a novel treatment paradigm and a new way of addressing mental illness so that it can lead to better and more compassionate treatment plans. And this is where psychedelic assisted psychotherapy, or PAP, comes into place. The protocol of PAP centers on producing powerful, non-ordinary states of consciousness through delivering psychedelic compounds in a clinical setting. It works via the induction of an experience with long-term positive mental health consequences, rather than a daily neurochemical correction for brain dysfunction. There are 3 phases of PAP. First, the preparation, then the treatment, and then lastly, the integration. Psychotherapists then help the patient integrate these mystical or unusual experiences into emotional, cognitive, and spiritual change. In PAP, there's an establishment of a therapeutic relationship, expectations of healing, and enactment of health-promoting activities, all based on the values of the patient himself or herself. The paradigm's conceptualization of mental wellness differs from both conventional pharmacological and psychotherapeutic approaches, though it is similar in that it does use specific drug actions to temporarily induce modifications in conscious experience and brain functioning. But the difference is that there's this conceptual expansion from drug efficacy to experience efficacy that makes this paradigm so much more considerate of the complex factors behind the human psyche. So if psychedelics do change beliefs, they do so mostly through the pre-existing psychology of the individual or the therapist engaging in the interaction. And so there's more autonomy and support for the client's inner-directed healing process, which helps bring one's life and relationships into the profound insights and massive shifts in experiences associated with those psychedelic-assisted expanded states of consciousness. The medicine enables us to consciously feel the emotions we have been unconsciously generating and that are responsible for our automatic interpersonal responses, which come out as habits or emotional dysregulation. It brings an indistinct, previously unrecognized emotion into the focus of immediate awareness to clearly identify and feel the state so that we can change it later on when it produces a trigger or distress. This profound healing through PAP can bring traumatized people huge transformations of their values and lives as moral beings. These reorganizations of values and remoralizations emerge spontaneously from within that are cultivated by this process, that therapists never direct specifically, but they help support the values of the patient. So it's less therapist directed and more patient directed. So to reconsider how PAP conceptualizes mental health, it first supports conceptually richer diagnostic approaches, which are more considerate of biopsychosocial factors and existential crises inherent to being human. PAP also deepens our understanding of which aspects of the therapeutic experience are most relevant for treatment outcomes. With the medical model and the psychotherapeutic model, you have the physiological changes and then the experiential changes. And if drug and talk therapy can be compared to psychedelic assisted therapy, which is also drug and talking, then there's something different fundamentally between the outcomes of the two. The positive correlations we found between subjective experiential features like ketamine's dissociative effects or psilocybin's peak experiences with positive treatment outcomes in depression corroborates that the meanings of the psychedelic experience play an important role curating mental wellness. The main assumption under PAP, I believe, is that humans heal psychologically through innate capacities that can be enhanced but not replaced by external interventions. And the framing of this paradigm differs significantly from conventional pharmacotherapy's emphasis on neurotransmitter pathology and the emphasis in psychotherapy, which requires more active and authoritative therapeutic stances. So my claim is that psychiatric intervention is a moral practice inherently. With psychedelic-assisted therapy, we have seen a breakthrough for how we view ourselves and our world. And as we learn to better reintegrate our anxiety and depression at successively deeper levels with new psychiatric paradigms, we become more conscious of our own emotions and less driven by automatic reflexive personality tendencies, and lets us be freer to react with more agency. So through these paradigms, we are trying to find the ones that will give us the most agency over our healing and the best outcomes in personal affect. The failure to understand that anxiety, depression, and trauma are a function of our society's values greatly limits our ability to help people who suffer from psychiatric conditions. It is essential for us to consider more than simply biological or neurological factors like emotional regulation, fear extinction, memory reconsolidation, and other conventional visions of healing that focus more on individual psychopathology, because they are not only socially and culturally decontextualized, but also disconnected from human values. We must understand the moral nature of people especially traumatized people and those with anxiety and depression and PTSD, to foster individual, relational, institutional, and social transformations that can reduce trauma and bring healing, happiness, and well-being to as many people as possible through new paradigms. Thank you.